Hello, guys. We're starting. We're continuing a neurology session. I think we should wait for people to come in first before we continue. So we have to start as soon as possible so that we can try and finish up neurology. Actually, the neurology. So we're actually dealing with the special senses, the eye and the ear. That's what we'll be taking today. And then tomorrow we'll officially be coming to the end of the neurology session as we'll be doing the neuropharmacology and then the slideshow session. So tomorrow will be officially ending pharmacology and special senses. So let's start. It's 10 minutes after 4 in my time, and then so today we'll be talking about otology. So it's like more like of the ear and the vestibular system. And then some certain things you got to know here. The first and foremost, most commonly tested concept on your otology is basically othalgia. So a lot of times when you take the step exams or you're dealing with or you're dealing with questions from the MBMEs, you're going to be asked about the othalgia. So otology, we're going to talk about othalgia. All right. And so there's certain things you're going to see in the question that might point to the etiology, right? And this stems from the anatomy of the ear, right? So we have the outer ear that sounds like the antenna or like the the sound catcher basically. And then it's transmitted through the external auditory canal, then to the middle ear, and then to the external ear, right? So what do you need to know for the STEPS exams? You just need to know the basic things here. I'm not going to talk too much about the basic things as regards the ear. So a lot is tested more about the pathology as against the anatomy and the physiology, basically. So um, we're going to talk about otitis, right? Otitis. I'm not going to dwell so much on this part of um, otology because it's not so high yield, right? For what is really high yield in the exam is actually the pathology. So we talk about otalgia. Otalgia just simply means earache, common symptoms, and there's some things that can give you some associations to it, right? Right? And earache can be primary or secondary, right? Secondary. So the secondary is usually as a result of the referred pain that can be from either a tooth problem, right? And then sometimes you can have pharyngeal issues, right? Because of, let's go back to the anatomy and show you guys. So this is the eustachian tube. And so sometimes you can have pharyngeal pathology that can be referred to the ear, and the patient can present with ear aches, right? As we're going to see as we're discussing about otitis. So otitis, basically, we have two types. We have media and we have external, right? And then we have external, right? And so the part of the ear that's affected in external is the external ear, just basically. So the patient will present with earache, otalgia, and then on examination, you see that the patient is having tracheal tenderness, right? And plus or minus, sometimes they can have discharge, right? And the organism that's commonly tested in the steps is for external, basically, is Pseudomonas. So you must know this. Pseudomonas aeruginosa, P. Okay, and this otitis externa is also known as the swimmer ear. So they ask it a lot in the exam. So it's very important that you guys know this. This is actually very high yield for the exam. They might give you a presentation of the patient, and they might ask you the organism that's causing the patient's symptoms. You must know this is actually very high yield for the exam. Another thing you need to know about this organism is that it's found in people who swim a lot. That's where that name swimmer ear comes in, right? Okay. So, um, just in addition to this, because it's kind of like high yield, again, to know for the exam is what we call malignant otitis externa. So, malignant otitis externa, right? So it's like a severe form of otitis externa. The only difference is that the patients tend to present with more severe symptoms, also more severe symptoms, so severe earache or otalgia. And then when you do an otological exam, what you'd see is there's granulation tissue in the external ear. So this is when you see this, most commonly the exam usually puts it in a diabetic patient, right? Patients who are diabetic, it's very common among these patients, right? Or patients who tend to be immunocompromised. Compromised. So that's where you see this disease condition usually, right? And so the symptoms are a lot more severe than that it seems, right? That's what you need to know for the exams. When you see a patient coming in has severe ear symptoms, otalgia, when you examine the patient, trigger tenderness is positive. You should be thinking more towards otitis externa than medial, right? And then this granulation tissue in the ear in a diabetic patient points more to malignant otitis externa or necrotizing otitis externa. You need to know that for the exam. Now, this is in comparison to otitis media. So in otitis media, what you have here basically is, so in otitis media, basically, what you have here can be as a result of basically two things. The primary reason is what we call eustachian tube dysfunction, right? Tube dysfunction. So let me just go back to this and try and explain what that means, right? So the eustachian tube is like connected to the middle ear, and most often than not, some people kind of have like an upper respiratory tract infection that kind of like comes in here, and of course the inflammation causes the eustachian tube to be engorged. And what's basically in here is air. So when you occlude here, the air is reabsorbed. And when the air is reabsorbed, it kind of creates like a negative pressure on the tympanic membrane, right? And that's one thing. The second thing that happens basically is that when there is inflammatory products that goes up the eustachian tube into the middle ear, it kind of like causes accumulation of purulent materials in the middle ear, and that pushes the tympanic membrane outward. And so the patients typically present with similarly like otitis, and they present with ear pain. And when there's a rupture of that tympanic membrane, the patient presents with otorrhea, usually very painful and purulent, right? So they present with ear pain and ear discharge that's usually very purulent. And what is also very high yield for you to know in the exam is the organism that causes this disease condition. Yeah. So I call them the shame organism. Shame. Right. So this stands for strep pneumoniae, Haemophilus influenza. And the type of Haemophilus we're talking about is the non-type R. So what it basically means is that this particular Haemophilus strain is uncapsulated, right? And then we have the meningococcal, yeah. So those three organisms, extreme organisms, causes otitis media, right? Of course, you treat them according to the causative organisms. The antibiotics you're going to use is going to be directed against the organism that causes the otitis media. So what you're seeing here on the slide is the bulging tympanic membrane, which is what I explained earlier on, that, when there's gathering of purulent materials in the middle ear, it kind of like exerts this pressure on the tympanic membrane. It also makes the tympanic membrane hyperemic as well. It becomes reddish and it bulges, right? And one of the complications of this basically is mastoiditis that occurs in children where, there's significant pressure in the middle ear that finds its way to the mastoid cells, right? Mastoid air cells. And the patient presents with this post-auricular pain. So one of the complications of um, otitis media, one of it is mastoiditis, and this is common in children, mastoiditis, right? Mastoiditis is common in children. It's a complication of otitis media, um, and this like post-auricular swelling, so just back of the ear. See the patient having this swelling, having this pain, right? When you see that in the exam, it's mastoiditis. This is also a common cause of meningitis in children. So meningitis can cause mastoiditis, mastoiditis can cause meningitis, depending on the spread of it, right? And another thing that can happen is brain abscess. So that's what I want you guys to know. So basically, what I'm trying to do in etology is that I'm trying to just make a quick summary of the topic. So part of it is high yield, some other parts are not so high yield, and we wouldn't bother about the parts that we basically don't need for the exams, okay? So next we're going to talk about is hearing loss. Yeah, so let's go back to this diagram. So you can see that this is like the cochlea, and it has two parts basically that are responsible for sound, right? You have the helicotroma, which is wide and flexible. So I usually use this mnemonics to remember it basically as, when you have a helicopter, before a helicopter ascends, before a helicopter ascends, it usually has a base, right? It has a base. So you have a helicopter, right? Helicopter. So so the helicopter stands for like the helicotra. So I usually refer to it as the helicotremor. So I just call it the helicopter. Right? The helicotremor. So a helicopter has a base. So that means that it's on the ground. It's low. So usually the helicotremor, if it's damaged, basically it affects low frequency sounds. Right? So a way to kind of remember it is like when you think of the helicopter, you remember that it's on the ground, and so low frequency sounds are affected first, right? And then the cochlea, the apex of the cochlea is where kind of like high frequency sounds are affected first. So why did I divulge into this? I was trying to talk about noise induced hearing loss, basically. So as you can see here, loss of high frequency sounds are affected first, and then usually leads to tympanic membrane. These are basically the high yield things you need to know for the step one exam. And then the next thing you need to know is the age related, just like what we have in patients with very pre like patients that just like more like a degenerative change that occurs in the ear. So basically, it's kind of like the osteoarthritis of the ear, right? Presbycusis, more like the osteoarthritis of the ear. So like there's kind of like degeneration of the so the cells that are responsible for um, sound transmission, basically. So I usually call prebicusis as the osteoarthritis of the ear. That's the way I kind of like remember it, right? So this is like the osteoarthritis of the ear, right? Osteoarthritis of the ear. That's how I remember it basically. So the osteoarthritis of the ear. That's what I refer to presbycusis as, right? So basically there's a destruction of the hair cells. So the hair cells are like tiny, like finger-like projections that kind of like transmits or generates the action potential that, that turns the mechanical event into an electrical event, right? So that's what the hair cells are. And so when they degenerate, the patient isn't able to hear very high frequency sounds. Unlike patients that have noise-induced ones, noise-induced hearing loss, that one affects more of the low frequency sounds, right? So that's actually a distinction between both of them. The pathology is what you need to know for the exam, the high yield stuff. The pathology, meaning that the hair cells are actually what is destroyed, right? Now, to that effect, we'll be talking more about hearing loss, which is actually high yield for the exam. And when I think of high hearing loss, anytime I think of hearing loss, the two tests that comes to my mind is the Weber and the Ryanese test. And it's very easy to just distinguish both of them, right? I'm going to show you guys a way I kind of like distinguish both of them. Very easy way to remember. When you step exams, you don't really need to think so hard. So you can just draw a table, right? Just draw a table, yeah, and you do this when in the exam, right? So you call here conductive hearing loss, you call here sensory neural hearing loss, right? And then you call here Weber and you call here Raynaud, right? So what I do is that I just label it as good, bad, good, bad, and bad. So this is how I like remember it in the exam. So it means that, for example, if the right ear is the bad ear, like you're having the problem with the right ear, so it means that the right ear here is bad, basically. And then in the sensorineural hearing, it means that the right ear is good. The ear that's affected is good. Um, Now, for the Ryanese test, both of them is like kind of like bad, but the ears are bad, basically. So well, how do I kind of like explain this now? So let's go to the illustration. And I'm going to tell you guys what I mean, right? So basically, the Weber's test, what you're trying to do is that you strike a tuning fork, and then you put it at the vertex of the head, right? When you put at the vertex of the head, for the normal patient, you're supposed to hear it at both sides. So it's not supposed to be louder at a particular pace, right? Um, so, but for the Weber's test, when you put it on the head of the patient, right, it lateralizes to the bad ear. So you can see from the table here, I put Weber in conduction here, and you can see that it's at the bad ear for Weber, right? For sensorineural hearing loss, you can see that it's localized more to the good ear. So you can see in the graph here, I put good for sensorineural hearing loss for Weber's test, right? When you put it at the vertex of the head, you try and ask the patient, where is the patient hearing it more? Is it the good ear or the bad ear? And if the patient is hearing it the bad ear, it's most likely a conductive hearing loss. And if the patient is able to localize it in the better ear, so let's say the right ear is affected, the right ear is affected, basically, the patient won't be able to hear it more in sensorineural hearing loss. But the patient will hear it more in the left ear that is good, basically, right? So that's what I meant by bad good, right? Then when you now go to Renee's test, basically, so what basically happens is that the normal thing you're supposed to do in Renee's test is that you take the tuning fork and then you strike it on the table and put it at the mastoid process. And then you ask the patient to, if the patient can hear the ringing sensation, right? And then if the patient tells you that he doesn't hear that anymore, you put it in the ear and you try and ask the patient, oh, do you hear it again? So it's expected that the air conduction is supposed to be better than the bone conduction, basically, right, in the Renee's test, right? But in conductive hearing loss, so basically the patient will hear it um, more when you put it on the master process, and then when you put it in the ear, the patient stops hearing that. So basically, what I mean is that if the pathology is in the right ear, right, you strike the rod, you put it on the master process, you tell the patient to hear it, the patient hears it for a very long period of time, and then you tell the patient, you put it in the ear, you put it on his ear, by the side of the ear, the patient can hear it. You take it back to the mastoid process, the patient can hear it. In that situation, the patient has a conductive hearing loss. But in the sensorineural hearing loss, basically, what happens here is that uh, so the the patient is able to hear it in the kind of like in the affected ear. He hears it more than when you hear it, than when he puts it in the mastoid process. So you strike the rod, you put it in the ear, the bad ear, that's the bad ear basically. And we put it in the bad ear, the patient hears it for a while, and then when the patient says he can't hear it, you put it in that same ear, that same bad ear basically. The patient hears it. So what this means is that for a normal patient and a patient with sensorineural hearing loss, the Raynaud tests are kind of like normal. That means the air conduction is greater than the bone conduction, right? What actually differentiates where it is localized is actually the Weber's test. So you need to do both of them. You can diagnose properly between conductive hearing loss and sensorineural hearing loss by just doing only one of these tests. You have to do the both of them, and that's why when you see in the exam questions, you see that they usually put two of them together basically because they know that you cannot diagnose hearing loss, conductive, or you can't differentiate any of them without doing the two together. I don't know if that makes sense, guys. I don't know if that makes sense to you guys. Okay, so let's go on, right? So that's hearing loss basically. So we're going to talk about two things before we round up this session on pathology. We're going to talk about cholesteatoma. So let me explain the pathophysiology of cholesteatoma basically. So um, okay. So the first thing you need to know is that the exams usually describe it like a pearly mass that's located in the ear. So basically, um, the outer ear, the outer ear basically has the type of epithelium it has is even in the auditory canal is keratinized, right? Squamous keratinized. Retinal squamous epithelium, right? And then what happens basically here is that the first way cholesteatoma can occur basically is that if this is tympanic membrane, this is eustachian tube, right? So infection comes in here. Someone has maybe an upper respiratory tract infection, basically upper respiratory tract infection, spreads into the nasopharynx and goes through the eustachian tube, causes inflammation around this region here, and then all the air is absorbed by the middle ear, and that creates a vacuum, right? That creates a vacuum. When there's an infection here, it goes up, it blocks this region here because of the edema, the recruitment of inflammatory cells, narrows the eustachian tube. So kind of like air is trapped in this place, and the air that's trapped here is reabsorbed by the middle ear. It's reabsorbed. So what happens here is that a vacuum, and you know that nature abhors vacuums, right? Nature abhors vacuum. And so what happens here is that it exerts a negative pressure on the tympanic membrane, causing a perforation. Causes perforation, right? And when this happens, this keratinized squamous epithelium that lines here kind of goes through that perforation to the middle ear. And what does this cause? This causes gathering of these squamous epithelial cells that undergoes oxidation and all the likes, and it becomes a mass, right? That mass that's formed as a result of the migration of this keratinized squamous epithelial cell into the middle ear and gathers is what we call a cholesteatoma, right? Another thing that can happen basically is if you have maybe otitis media, so there's already a perforation due to an infective process. There's a normal migratory pattern of this keratinized squamous epithelial cells into the middle ear, and that basically just leads to a cholesteatoma, right? So the exam describes it as a pearly mass in the middle ear, right? Middle ear. So let me write middle ear, ME, right? So that's what basically happens in the pathophysiology of cholesteatoma, right? And usually it's cured by surgery. So surgery is the definitive management, right? So it's a mass. It's going to cause mass effect on the middle ear, and so you have to excise it out. So surgery is the treatment of choice for cholesteatoma, right? So I just wanted to use that to explain to you guys what it's all about, right? And so vertigo basically is spinning of sensation of spinning around. So basically what happens is that the patient describes it as kind of like he's standing still, right? Is the patient is standing still. And then it's like the room is going round and round him, right? So first time you see the chair in front of him, the next time the chair is at the back, the next time the chair is at the side. He has that sensation that the chair is kind of like moving around him, and that kind of leads to an unsteadiness, right? Right. So so there are two types of vertigo. There's central and there's periphery. The steps likes to test the difference between these two. And one of the commonest difference between these two that I would like to highlight is that the periphery is never associated with vertical nystagmus, right? The periphery, no vertical nystagmus. So you will never see vertical nystagmus in a patient that has peripheral vertigo, right? That is one key distinguishing feature between both of them. There are other features, but I think for now this is the key feature I can remember. This has vertical nystagmus. Vertical nystagmus, right? So that's like the first key difference between both of them, right? And of course, the word central means that the cause of the vertigo is from the brain, right? So it's from the brain and spinal cord, right? And cranial face, right? Right. So there's a maybe brain lesion, the brainstem lesion tends to present with central vertigo. If there's an ear lesion or cranial nerve 8 lesion, it presents more with the peripheral vertigo. So you need to know that difference, right? So that's what I was trying to tell you guys here. It's never vertical. That's the key thing, right? Another thing you need to know is by fixation, right? It's not it's suppressible by fixation. And what does that mean basically? Let me try and explain that so that you guys can have an idea of what that means.
Doctor, could you repeat the last line you told? Just which one is more like distinguish symptoms between two?
Sorry, I didn't get your question, Doc. What did you say?
Like you said, is it nystagmus is the distinguishing feature for both peripheral and central vertigo?
Yeah,
Which
no, I was
symptoms?
trying to say, yeah, I was saying that vertical nystagmus, right? In a patient with peripheral vertigo, the patient doesn't have what we call vertical nystagmus. So we have three types of nystagmus, right? Nystagmus basically just means eye movement, right? Eye movement,
Yeah.
saccadic eye movement. Yeah, so for the peripheral vertigo, it's never associated with the vertical nystagmus, right?
Okay.
It's
Okay.
never associated with
Mm.
it. So if you see a patient having vertigo and then has vertical nystagmus, it's more central than periphery. That's what I'm trying to say.
Okay. Thank
Yeah. Okay. So now I was trying to explain what they mean by head fixation, right? So the head is spinning round and round and round and round and round, right? And the reason why the ear is kind of like spinning around is because of some kind of like small stone-like substance in the ear, right? And they're called otoliths, right? Otoliths, right? They're like otoliths, they're like stone-like regions. So when the patient is having the vertigo spinning sensation and you are able to steady the head, you are able to steady the head. So we call that reflex. It's a reflex, they call it. They call it, I think, vestibular, oculovestibular reflex. So they call it oculo. I'm trying to explain something here, right? Oculovestibular reflex, right? So I don't know if you guys have noticed when you were children that like when you're going round and round, you're rotating round and round and round and round and round, you notice that your eyes are turning and then all of a sudden you start having after you have stopped, you notice that you have this unsteadiness. Like when you're going around as children, you're playing, and you're turning around a particular point. And then when you stop, you notice that um um you continue having vertigo basically, still continue having this unsteady gait even after My network just went out. I'm really sorry about that. I don't know why it just went. It just says that. Can you guys hear me? Okay. Okay. Yeah. So let's continue, right? So I was trying to explain that basically, right? So where was I basically? So I was trying to explain the causes. I was trying to explain the oculo vestibular reflex, right? So the patient is spinning round and round and round and round and round, and then the patient stops all of a sudden, and then he still has this steady this what do you call it? This certain level of vertigo before the patient stops all of a sudden. So what causes that basically is that the eye, this particular reflex, takes over and vertigo even after stopping that rotatory movement, basically. So um yeah, so the patient goes round and round and round and round and round, and all of a sudden stops. And immediately the patient stops, um the patient has level of that's still that's a remnant vertigo that the patient observes is actually as a result of this oculovestibular reflex, right? And so when the patient has peripheral vertigo, what you do at what you're trying to do is that you can see that it can when you're able to fixate the head, like the patient has the vertigo, if you're able to fixate the head, which is what happens in that state where you're going round and round and round and round, and you just stop the head. You stop the head from like moving. Basically, you can alter, you can suppress the vertigo. That's it's basically because of this reflex that I just mentioned, this oculovestibular reflex, right? So that is why the peripheral vertigo is kind of like suppressible by head fixation. So you just tell the patient to steady the head, and then you are able to take the patient out of that vertigo, which is what happens when the patient is rotating, 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 and then he stops. It continues for a while, and then when you fixate the head, you tell the patient to stay still. And if the patient stays still, you notice that about a time the vertigo will subside. So that's basically what just happens there. So for the peripheral vertigo, you can suppress it by tell the patient to keep the head still so that those otoliths can assume their normal position, you know. So because when you're rotating, they are moving at a very fast rate, right? And so they need to stay steady before the patient won't have the vertigo again. So those are like kind of the ways you can differentiate both of them. I don't know if the explanation is very clear, or should I go over it again?
Please try to go over it again, because the one you explained initially was peripheral vertigo, right?
Yeah,
That you
peripheral
said it
vertigo,
is
yeah.
suppressed by fixation.
Head fixation, yeah, yeah. So what I was trying to say basically is that I was trying to give you an illustration. When you were a child, like when you were kids, right? There was this game that we used to play where we'd go round, we'd stand on a particular place, and then we'll be going round and going round and going round and round. We're standing, but like we're turning, right? We're turning round and round and round. And what that does basically is that you're trying, like, you're displacing the otoliths. Otoliths are like sound-like substances in the inner ear, right? They're like inner in the inner ear. So and so when you're going round, basically you're displacing those otoliths, right? And what happens is that you would observe that when you stop going round, basically, you would observe that you still be having this sensation of vertigo. And the only way for you to get out of that sense of, you know, still going round after you're stopped is to stay still. Like you just have to keep your head still. Like if you keep your head still, you observe that that sensation of spinning around gradually fades out, right? And the reason why that thing happens, basically, you have that feeling of, you know, you're turning your eyes and you're having vertigo is because of this oculovestibular reflex. That's what I'm saying. I'm trying to explain this oculovestibular reflex for you guys, how it comes out basically. It's as a result of that turning that you're having, and you're turning, and it leads to vertigo because it's a peripheral cause. It's the vestibular nerve that is you know, like mediating that reflex. So that's why when you keep your head still, you can snap out of that vertigo, right? And that's what I was just trying to say basically, like that the peripheral vertigo can be suppressed, can fade away by head fixation, meaning that if you stay still, that time that you stay still, that you still have that remnant vertigo, it rapidly fades out because you are staying still. That's what I'm just trying to explain. I don't know if it makes sense, guys. I don't know if what I'm saying is makes sense. It's only people that like were children that played with these things that will understand what I'm saying. Yeah. Um. So the central vertigo basically has to do with a stroke or a tumor causes nystagmus in any direction. It's usually vertical. So central vertigo usually presents with vertical nystagmus. That's something you must know. And of course, because it has nothing to do with the otoliths, it has nothing to do with the otoliths. It's not mediated by the oculovestibular reflex. It means that you can't suppress it with head movements, right? Head fixation, rather. So that's what I'm just trying to explain. So you should just know those two things, and it'll be a lot more easier for you. So those are the two things you should know about the nystagmus associated with central vertigo, right? Are there any questions here at this point? Do you have any questions? Okay, so in the absence of any questions, I think we're done with otology, but there are some conditions we have to talk about that are very high yield for the exam before we leave otology, right? I just have to talk about them because they're very high yield for the exam. They come out a lot in the exam, especially step one. Um, so I just have to talk about them. And there are three conditions basically that we're going to talk about. We're going to talk about the BPPV. We're going to talk about Meniere's disease, and then we're going to talk about VM, vestibular neuritis. So I'm just going to take a time to cover every one of these because they come out in the exam and they're very kind of like high yield for you to know how to differentiate them, right? So for the BPV, basically, what the patient has basically is that the otoliths in the so they have this like episodic kind of like episodic vertigo, right? That is usually triggered by head movements, right? Head movements. So they have this episodic, so this is BPPV, right? They have this episodic vertigo that is usually triggered by head movements. And the good thing about it is that there are no other associating symptoms, right? So these patients don't usually have nystagmus. These patients don't usually have ataxia or any other thing. So I usually call it like the naked vertigo, right? Because it's just plain. You don't have anything associated with it. The BBPV, nothing is associated with it. The patient just has this episodic vertigo with no auditory symptoms, basically. So there's no hearing loss, there's no other thing. The patient just has episodic vertigo. It comes on and off, basically, and you're able to diagnose it by using the whole depicts all depicts. Sorry if I'm not spelling this thing wrong. Deep sea maneuver, right? So it's a maneuver used to diagnose it. You don't need to know how it's done. All you just need to know that there's a maneuver that you can use to diagnose it, right? This is how you diagnose it. But when you want to treat it, you do what we call the Epley's maneuver. You just need to know this. I don't think they will ask you so much on how to demonstrate it, right? So maneuver, right? Sorry guys, let me clean this. The patient has episodic vertigo with no other auditory symptoms, right? So there's no hearing loss, there's no nystagmus. You are able to treat it with doing the Epley maneuver, right? And then you diagnose it by doing the whole deep sea maneuver. That's how you diagnose it. How do you treat? Basically, lifestyle modification, avoid sudden change in direction, and then you can use some drugs, some antihistamines. I think usually first generation antihistamines, cyclizine, and the rest, right? Cyclizine and the rest, right? So this is what you use to treat it basically. And then the next one we're going to talk about, that's what you need to know about BPV. So they'll give you a patient. Yeah, go on.
Could you please repeat the maneuvers? Deep sea and airplane.
Yes, so this is the diagnosis. This is how you treat it, right? So this is how you treat it. Let me clean this. This is how you treat it. Use the Epley, the Epley maneuver is a therapeutic. So let me write RS here. So it means that this is the cure for it. This is how you treat it, right? Use the Epley's maneuver to treat it. The whole deep sea maneuver is what you use to diagnose it, right? Diagnose. So you're not doing any imaging, you're not doing anything, you're not doing any laboratory investigation. If you want to just diagnose it, you do the whole deep sea maneuver. And then when you want to treat the patient, you do the Epley's maneuver. And the only time you can use therapeutic pharmacological means of treating benign positional paroxysmal vertigo is when it's so severe that the Epley maneuver doesn't work. And so you use the first generation antihistamines such as cyclizine, meclizine, and the rest. Those are when you can use it. When the Epley maneuver fails, then you use this. But usually about 90% of the time, the Epley maneuver is more than enough to treat the patient, right? Is that okay? Did you get that?
Could you please describe the maneuver? How we will perform it?
You don't really need to know that for the exam. Nobody will ask you that for the exam. I
Okay.
don't think you should
Just
stress
we
yourself.
note the name of the maneuver. Just we note
Yeah,
down the name of.
yes,
Okay.
yes. Just know the name. Just know the name. That's the first thing. Know what it's used for. Nobody will ask you that for the step one. Nobody's going to ask you that for the step one. So don't just yourself on knowing things that won't help you. Just focus on what you need to get those points for your step one. Um, um, just know that the whole DIPSY is what you use to diagnose, and then the EPLI is what you use to treat. Basic. I've gone through a lot of U-World questions. I've never seen them asking you on how to demonstrate it. They won't ask you that. No MBM question, I'll ask you that either. All right. So I was
So,
talking about the yeah,
doctor, what is the
yeah.
main cause of this paroxysmal, benign paroxysmal positional
Okay.
vertigo?
Yeah, okay. So the mechanism, the pathology, the basic pathophysiology is like it has to do with those stones that I told you that in the semicircular canal in the inner ear. Like
Stone?
so they are like, can you hear me?
Yes, I can hear you.
Yeah, so they are like stone-like particles in the semicircular
Okay.
canal. Yeah, stone-like particles in the semicircular canals known as otoliths, right? Otoliths, right? And so what happens basically is that, so what happens basically is that these otoliths tend to have this abnormal positioning or fixation in the semicircular canal, abnormal fixation or positioning in the semicircular canal, right? Right? Abnormal position or fixation, right? And so these patients tend to be at risk of having vertigo because of the positions of these otoliths, basically. So when they have a slight change in head movement, slight change in head movement, they come down with this episodic vertigo, basically, right? So abnormal fixation of the otoliths in the semicircular canal causes the BPPV, right? There's an abnormal fixation or position of the semicircular of these otoliths in this semicircular canal in the ear. So let me show you guys what the semicircular canal is. All right.
So,
Let me show you.
doctor, is it started all of sudden?
Yes,
Like,
usually sudden.
has it?
Yeah, it's sudden. So this is like the semicircular canals. You're seeing the semicircular canals. Right? Can you hear me? Hello?
Yeah, doctor, I can hear you.
Yeah, so like this is semicircular canals, and then these otoliths are found here, right? And so these otoliths are found in a very abnormal position. So they are supposed to be positioned in such a way that when you tilt your head, you're not supposed to have vertigo. But for this group of patients, basically, there's kind of like an abnormal positioning. So the ones that are supposed to be up here are located down here, right? And the ones that are supposed to be down here are located up here. And so these ones that are here are not kind of like used to the, because these semicircular canals are aligned in such a way that every movement that your head undergoes, you're able to have this steadiness. How will I put it now? So you're supposed to have a certain level of steadiness when you move your head. And the reason why you have that level of steadiness, so if you're moving your head posteriorly, you're not supposed to experience vertigo because the otolith in that semicircular canal, maybe the posterior semicircular canal, would move and then adjust itself rapidly, right? But in patients with BPPV, once the otolith moves, right, it doesn't come back to its position as rapidly as it's supposed to, right? That slowness of movement causes it's what actually causes the vertigo for them. So there's a slowness of return of the otoliths when they move from a particular position to the other, right? So they're kind of like displaced. Let me just use that word. They're kind of like displaced. And so these patients usually come down with vertigo, right? That's like the simplest explanation I can give. I don't really know if it makes sense to you, right?
Yeah, thank you, doctor. Yeah.
Yeah. Okay, so I'm taking so long on this topic right now. Okay, so just so that you guys can just understand what happens, right? So abnormal fixation or abnormal movements or position of this otolith in the semicircular canal leads to BPPV. And then you diagnose it by using the Hall-Dipsey maneuver, and then you treat it by using the Epley's maneuver. That's simple. That's all you need for step one. You don't need anything more than that for step one. That is what's going to be tested on the exam day. Nothing else. They're not going to ask you any other thing about it. Okay, so let me try and talk about vestibular neuritis, right? So does anybody have an idea about vestibular neuritis? Does anybody have an idea
It's
about it?
the post-viral inflammation of the vestibular nerve.
Yeah, so what happens to it? What happens to vestibular neuritis? What happens there? Does anybody have an idea?
They have beta and
Yeah,
also
so
maybe
okay,
imbalance.
go on, Dr. Fatima, go on, I can hear you.
I think it is post-viral inflammation of the vestibular nerve
Yeah,
and vertigo and imbalance and nausea.
yeah, so yeah, you're right. So post viral infection of the eighth cranial nerve of cranial nerve 8, yeah, causes vestibular neuritis. And so basically these patients tend to have like vertigo, and it's usually peripheral vertigo. So all these things I'm listing are example of peripheral vertigo, right? So usually they put in the question a patient who had an upper respiratory tract infection or a viral infection, and then the patient presents later on with symptoms of vertigo, nystagmus, and ataxia, basically. So the patient will present with vertigo, ataxia, and nystagmus, right? Nystagmus. So let me just put N, right? The patient doesn't usually present with hearing loss, so there's no hearing loss. So no hearing loss for patients with vestibular neuritis. There's no hearing loss, right, for them. But when hearing loss is indicated, when the patient has symptoms of vestibular neuritis and hearing loss, that is now called labyrinthitis, right? So let me just call it labyrinthitis, LB. So if a patient has vestibular neuritis and hearing loss, what you have, so let me write VN plus unilateral hearing loss. So that's labyrinthitis. So a patient who presents with symptoms of vestibular neuritis and then has unilateral hearing loss, the patient has labyrinthitis, right? If there is no hearing loss, it's just purely vestibular neuritis, right? That's what I want you to guys. It's usually self-limiting. That's one thing you know because it's a viral infection. This is what you just basically need to know for the exam. I'm not really going to talk so much about any other thing here. This is what you need to know for the exam. Usually presents as a patient who had a viral infection, and then some weeks or days later, the patient starts having features of vertigo, nystagmus, ataxia, but there's no hearing loss. So the hearing part, the hearing part of the cranial nerve 8 basically is not typically affected, right? But if the auditory part of cranial nerve 8 is affected, the patient will have labyrinthitis, right? So that's the way you can just differentiate both of them, because they can put this as part of the options in the exam. I wish I had questions here. I would have shown you guys. You can also see them in MBMEs as well. When you do MBMEs, you can see them as well, right? The last thing I'm going to talk about here is the last disease condition I'm going to talk here is about Meniere's disease, right? So that we can go to ophthalmology and try and round it up, right? So you have. Does anybody have an idea of what Meniere's disease is all about? So what happens in Meniere's disease? Does anybody know?
Yes, in the Meniere's disease, there will be the accumulation of endolymph in the semicircular canals.
Thank you so much, doctor. So there's accumulation of endolymph, yeah, endolymph. So endolymph in the semicircular canal, right? So endolymph is like the fluid that you find in this region here. Fluid that is found in this region here, and it's that fluid that the otoliths are kind of like suspended in, right? Those sand-like particles, they're kind of like founded in this semicircular canal. Also, the endolymph is found here, and so there's accumulation of fluid in this endolymph, in this semicircular canal, that leads to increased pressure, right? And then majority of the patients here present with the sensation that their ear is full, and that is very, very high yield for you to know. So when you see a patient that has this sense of ear fullness, like they tell you that, oh, doctor, I feel like my ear is full, it's making a whooshing sound. So ear fullness. This is very, very high yield for you guys to know. High yield, right? So patients with Meniere's disease present with ear fullness. They present with also auditory symptoms such as hearing loss, right? Hearing loss. So they present with nystagmus, they present with almost everything. And it tends to affect older patients, right? Older patients. So another clue that you can see in the exam is that they'll tell you that the patient is old, around 60 years and above. So 60 years and above, greater than 60 years, right? The patient presents with ear fullness as a result of increased accumulation of endolymph in the semicircular canal, okay? And then the patient has this sense of fullness in the ear, sense of hearing loss, nystagmus, and all the other symptoms, right, that the patient will have. And then when you want to treat the patient, the first thing you do, some people tell you weight loss. Apart from weight loss, you can also give the patients diuretics in some cases, control the BP. So BP control is very important in patients with venereal disease. Some people say weight loss is also important. And then, of course, diuretics can also help, although it's rarely used. And then for symptomatic treatments, when the patient is having, then you treat some symptomatically. So if the patient is having vertigo, you can give H1 blockers. So you can treat symptomatically, but these are drugs that you can use to treat Meniere's disease, right? You can control the BP, weight loss, give diuretics. You can give H1 blockers, cyclizine, meclizine. These are drugs that also help, right? So they won't test you on all of them, but one of the most important things that they may test you on in controlling Meniere's disease is the use of BP control. That usually comes out a lot in the options to treat a patient with Meniere's. Okay.
Sorry, what's the pathogenesis of this fluid that accumulates there?
So basically, a lot of times Okay, Dr. Vanessa, you have a question?
Sorry, that's an
Okay,
error.
so let me show you some. Yeah, okay. So basically, what happens here, let me just put it like, let me just try and explain what happens in Meniere's disease, right? So basically, sometimes it's majority of the cases of Meniere's disease is usually idiopathic. So it's about a large percent of it is as a result of usually multifactorial and usually genetic or idiopathic. Let me just use that word. So there's no really clear-cut reasons why for some patients they tend to have an increased amount of endolymph in the semicircular canal. But a lot of people usually postulate that one, there could be an occlusion in how the endolymph is drained, basically an occlusion in how the endolymph is drained. That's one theory. But the widely acclaimed theory is that usually it's usually idiopathic. There's usually no known cause, right? There's usually no known cause most of the times. And then some postulate that there's usually occlusion of how the endolymph is drained, basically. That's one. And then some people also postulate that there's usually increased production of the endolymph. So let me go down and draw this, right? So um, so there are like three theories that have been postulated. The first one is usually genetic. So there are genetic reasons. So this kind of has like a lot of genetic underlying as a cause of the pathology. The second reason is that sometimes it's usually just increased production of the endolymph. For some people, they tend to produce more endolymph than others. So increased production of the endolymph, right? Increased production of the endolymph. And then for some other persons, there's kind of like reduced drainage. Although all these are possible reasons though of the endolymph, right? These are like two reasons that have been speculated, but most of the times it's usually genetic or idiopathic. That's what I have to tell you about it, from what I know about it, Sean. What I've read and known about it, basically. So patients kind of like have this tendency to kind of like produce a lot of endolymph, basically. A Nigerian president actually suffered from this. A Nigerian president, Muhammad Buhari, suffered from this. And there were like postulations that his grandfather may have had it, his great grandfather may have had it. There are a lot of stories then about it, but it tends to have a genetic underlying cause, right? Um, so that's what I'm going to say about these three conditions. They come out a lot. Just know how to manage them. How to manage them is high yield as knowing the pathophysiology and not the symptoms. Okay? They are high yield concepts that you must know. Do we have any questions? Because I think we're done with otology. I want to go to ophthalmology now. Okay, so let's go to ophthalmology. So what you need to know here, basically, the anatomy of the eye. This is basically the eye. So that's three layers. It has the retina, the choroid, and the sclera. The sclera is protective. The choroid has the basic function of nutrition, and then the retina stands. Basic function of the retina is for sensory input, to receive sensory input. And so the retina has the optic nerve, which is direct. The eye, basically, as a whole, is a direct extension of the diencephalon, right? How many of you guys remember that? The diencephalon, the eye directly is an extension of the diencephalon, right? So it's actually more of like a neural tissue, right? A neural tissue outside the brain. And so it's one of I would say it's actually the most important sensory organ, right? You can survive without hearing, you can survive without tasting, you can survive without smelling, but the chances of surviving without seeing is almost practically impossible, right? So it's the most important sense organ, right? And there are certain pathologies that affect the eye. So you can have, starting from the cornea, which is this outer layer that protects the kind of like the iris, right? This cornea is like a transparent material that kind of like protects the iris. It's an extension of the sclera. So the sclera, the cornea is an anterior extension of the sclera, right? And it's protective, like I told you earlier on, that the sclera is protective. And so you can have a situation where this cornea, because it's exposed to the outer part of our body, the other part is covered by the extraocular muscles, some fascia and all that. But the part of the sclera that is exposed is the cornea, and hence this part is exposed to a lot of insults, chemicals, viral organisms, and the likes. So this part can be predisposed to inflammation. And when you have inflammation of this region, you have conjunctivitis, right? And then there are three types. You have allergic, bacterial, and viral, right? It's commonly tested in the exam where a patient, and usually confused with anterior uveitis, right? What you need to know, that there are subtle differences between both of them, between conjunctivitis and anterior uveitis, right? So for the major difference between conjunctivitis and anterior uveitis, one is that, which is what I want you to know for the exam. It's very, very high because they bring it a lot in the question, right? They bring it a lot in the question. They usually try to confuse students between anterior uveitis, acute closure angle glaucoma, and then uveitis. So for patients with uveitis, to differentiate it for conjunctivitis, so CJ and anterior uveitis, this tends to affect the pupils. Right? And this doesn't. So the pupils are spared in conjunctivitis. Pupils are spared, right? So that's one way you're able to recognize, differentiate between both of them. So when you see a question that telling you about the patient came with red eyes, the patient is having blurry vision or visual loss or whatever, and they tell you that the patient's pupils are not dilated or are not affected, you should be thinking of conjunctivitis. But here it affects the pupil in anterior uveitis. So you just know that for the exam, it's kind of like high yield. It's kind of like tested. So the patient has red eye, and you can see that the pupils are not affected, the iris are not affected.
So please repeat that. Repeat
Just the
that,
transparent
please.
layer and the sclera that is affected, basically, right? For bacteria, for viral viral causes are the most commonest, and they tend to be self. Okay, I should repeat the anterior, right? But for conjunctivitis, the pupils are not affected. So they won't tell you, oh, the patient has a dilated pupil or the pupils are affected. You won't see anything like that for conjunctivitis. But for anterior uveitis, the pupils are mostly affected, are almost always affected. So in an example situation where you are seeing conjunctivitis, anterior uveitis, and the right, if you see that the pupil is affected, the answer is most likely anterior uveitis. If you see that the conjunctiva or the cornea is not affected, basically, or the conjunctiva is not affected, or the pupils are not affected, basically, you should be thinking towards conjunctivitis. If the pupils are not affected, conjunctivitis. If they are affected, anterior, right? Both red eye. Red eye. So if the patient has pupil involvement, you're thinking of anterior uveitis. If the patient has no pupils involvement, you're thinking of conjunctivitis. That was what I was just trying to say. Do you get that? Okay, so let's go. Very simple to understand. So what happens here is that for those who are far-sighted, the images are formed behind the retina because the eyeballs are too short. So too short. The eyeballs are too short, right? The eyeballs are too short. For people who are far-sighted, they have a very short eyeball. And so this hyperopia. The eyeballs are too short. So the image is formed behind the retina, right? So those are people that are far-sighted. But for people who are long-sighted, the eyeball is very long, right? You can see the difference between both of them. So the images are formed just in front of the retina, right? So this it's too long eyeball. So what to treat this condition, you need to use a converging lens to treat the to treat patients with what do you call it, with farsightedness or hyperopia. To treat patients with hyperopia, basically, you have to use a lens that makes the image converge much faster, right? So that the image will converge, will try and like form in front of here. So it's a converging lens you use. But for a short-sighted person, so short-sighted, that's myopia. For myopia, you use a diverging lens. So diverging lens will allow the image to be formed just right in front of the retina, right? That's just basic physiology. That's just the basic thing that happens here in hyperopia and myopia. So in hyperopia, that's farsightedness. The globe is too small, hence the image forms behind the retina. But for patients who are myopic, the images are formed just before the retina. Hence, the image is formed here, and they are short-sighted, right? So to correct this, basically, you use a lens that causes diverging points, right? So the diverging lens would kind of like cause the image to be formed just at the retina. But for here, you have a converging lens, right? So the converging lens tries to bring the images closer to this point, right? And this one, it tries to bring it farther to hit this point. I don't know if this makes sense for you guys, right? It's very easy to understand, right? Okay, so can you hear me now? Is my voice much clearer? Or I don't know, maybe I should increase the volume of my it's my okay, let me increase my voice. So can you hear me now? Okay, so I guess everybody can hear me, right? So that's what happens for hyperopia.
Yeah.
Let me go over it again. Okay, yeah. So for hyperopia, basically for farsightedness, the image, if you use a lens that converges it at causes a early conversion of the image to just hit the retina. And then for the short-sighted, you use a diverging lens that prevents the early converging of the image so that it can hit the retina just at the right time. So for astigmatism, basically, commonly tested, there's abnormal curvature of the cornea. So so this is the cornea, right? So ideally, it's supposed to be kind of like this, but for patients with astigmatism, it's kind of like there are like numerous curves on the cornea, and so light hits at it at different angles. Light is supposed to hit at it at a straight angle, right? Like all of it, right? Focus the image, right? But when the light hits for patients with astigmatism, they kind of have like abnormal curvature of the lens due to the degeneration of old age. and then it hits the lens at an acute angle, and hence it has it doesn't travel like in kind of like in the straight line, so it goes in very wavy kind of like projection, right? So you do is that you can't change the lens of the cornea of the patient because the lens and then go and kind of like corrects light in that the lens that accurate because of how dense normally.
Doctor, your
Doctor, we
voice.
can't hear
So
you.
like, so let me go
Your
over
voice is
let me
break.
again. Astigmatism. Ideally, supposed to be smooth, straight, you know. Yeah.
No, doctor, your voice is so breaking. We cannot hear you.
Let me try and fix this thing. I'm sorry. Let me fix this quickly, right? Can you guys hear me now?
Yeah, we can.
Okay, can you hear me now?
Yes,
Hello?
doctor. Yes,
Okay,
doctor.
great. Okay. Yeah, okay, great. Yeah, okay, great now. So what I was saying about astigmatism, is that so basically for a normal person, right, the lens is supposed to be smooth. The cornea, right, and the lens is supposed to be smooth like this. The cornea and the lens supposed to be smooth, very, very smooth. The edges are not supposed to be rough, right? They're not supposed to be rough because light hits at it at a very straight angle here, right? But for patient with astigmatism, basically what happens and what you can see here is that the patient has the cornea, basically the cornea. This is the cornea, right? This is the patient with astigmatism. This is how the cornea looks like. And so when light hits at this place, there's an angle that is formed between this point and this point, right? But you can see that the angle here is kind of like a 90-degree. Here you have an acute angle, right? And when light hits at an acute angle, it kind of like refracts it. If you're doing your physics practical when you're in school, you notice that when light hits a transparent object at a particular angle, it kind of like refracts it depending on the angle in which it hits that prism, right? So that's the same thing that happens in astigmatism. Because the cornea is kind of like rough, it forms like an angle between the angle at which light hits it, right? And the cornea. There's an angle that is formed, usually an acute angle. And so the light is refracted, it's slightly refracted, as against when it hits it straight. When it hits it straight, it just goes to the lens directly. There's no large amount of refraction. Okay. So to correct this, you give a cylindrical lens. And what that cylindrical lens does is that it does the function of the cornea, but it kind of like corrects that acute angle that is formed here. Let me use here as an example. It kind of like corrects that acute angle here. So instead of hitting the lens at an acute angle, it hits it at a straighter angle, right? So that it prevents that wide refraction of light, basically. So that's what the cylindrical lens does for astigmatism. Astigmatism basically is that the cornea has an abnormal curvature, right? And the curvature could be at the middle, could be at the end, could be at the side, anywhere. And so you give a cylindrical lens to try and prevent the refractive potential that occurs when light hits the cornea at an acute angle, basically. So that's what I'm just trying to explain. I don't know if it's clear. Do I have to go about it again?
It's
Okay.
clear, doctor.
Okay. So presbyopia is like, let me explain this now. You know, I told you guys that when we're talking about presbycusis, right? I was talking about presbycusis as the osteoarthritis of the ear. So this is the osteoarthritis of the eye, right? This is the osteoarthritis of the eye. I call it the osteoarthritis of the eye. Like degenerative changes are happening in the lens. So presbyopia. So I call it the osteoarthritis of the eye, right? The osteoarthritis of the eye. So osteoarthritis of the eye. So basically, it's just degeneration, age-related degeneration of the lenses, right? The lenses are weak. The ligaments are suspended are also weak. So the patient's vision is greatly affected. And so the patient will need, you can see, basically what happens here is that age-related impaired accommodation. So basically the lens is basically weak. So it can't do its basic function of accommodating light, which is one of the major functions that the lens is supposed to do. So I usually call it the osteoarthritis of the eye. That's how I call it basically. Osteoarthritis of the eye. All right. So the lenses are weak. These lenses are weak. Suspensory ligaments are weak. Hence, what makes the lens weak is because the lens is very elastic, right? It's very elastic. And so the elastin fibers in the lens are reduced. Hence, the lens will be able to do its basic function to help with accommodation, right? So loss of elastin in the lens leads to presbyopsis because it's degenerating. As you age, it's wearing out, you know, and it's not getting replaced. So the patient comes down with presbyopsis. So there's reduction in how the patient is able to read. And you know, when you want to read, you need to accommodate. So if I'm reading this, if I bring a paper close to me, I have to kind of like accommodate it. I have to change the diameter of the pupils. Either I stretch the lens, either I'll have to stretch the lens more to take a lot of light to accommodate. And if I'm in a bright situation, so basically this is what happens. If I'm in a very well lit room, uh, the tension on the lenses is reduced if I'm in a very well lit room. The tension on these lenses here is reduced. But if I'm in a dark room, right? I'm in dark room, the tension here increases, and the reason why it increases basically, let me use here to draw this. So let me use here to draw this. So in a dark room, the lens is stretched by these suspensory ligaments so that it can try and take in as much light as possible, right? And the reason why the lens can stretch is because there's elastin fibers here. So in presbycusis, that elastin fiber is lost. That elastin fiber is lost. The fiber here is lost. And hence the patient's lens won't be able to stretch to accommodate light, you know. So that's what basically just happens in presbycusis, right? Cataract, high use for the exam. Yeah, okay. Yeah,
Presbyopia.
presbyopia. What do you want me to explain about presbyopia?
Said presbycusis.
Okay, presbycusis. So I was saying that I used to call anything pressed by osteodegenerative changes, right? For the presbycusis, basically, there's degeneration of the hair cells in the organ of Corti. But for presbyopia, there is degeneration of the what do you call it? The elastin fibers in the lenses. So the lens is not able to do its basic function of accommodation, which is what I just explained here. In order to accommodate, light needs to enter into your eyes, right? And the lens helps with that. If you're in a dark room, the suspensory ligaments stretch the lenses. They kind of like make the lens thin out so that it can gather a lot of light, right? And if you're in a very well lit room, it relaxes so that, you know, light goes in normally. But for patients with presbyopia, they can't do that. They won't be able to accommodate. So they won't be able to see well in a dark room. They won't be able to see finely printed notes and all that because they can't accommodate. They can't alter the structure and configuration of their lens, right? That's what I'm just trying to say with presbyopia. For presbyosis, the opposite is different, basically. So the organ cells, the hair cells of the organ of Cotillard are actually destroyed. Hence, the patient can't respond to high frequency sounds because those hair are located. We have where the hairs are located. We have at the helicotrema and we have at the cochlear apex, right? So the ones at the cochlear apex is the one that's majorly affected. So high frequency sounds, they won't be able to hear them for patients with presbycusis, right? That's what I'm just trying to say. I don't know if it makes sense. Cataracts, one of the causes of the red. Okay, so let me just explain cataract. So the lens is this is the lens, right? So what happens here basically is that the lens is basically kind of like transparent. So it means that light can pass through it, right? And then what happens with cataract is that the most common cause basically is that there's osmotic damage, right? Osmotic damage, meaning that it accumulates osmotically active substances. It could be glucose, it could be sorbitol, it could be anything, or it could be a damage to the lens. There's inflammation going on, protein, gathering of protein within the lens. Anything basically that can make the lens opaque causes cataract. So it could be an infection, it could be a metabolic disorder, it could be an infection, it could be a metabolic disorder, it could be a congenital disorder, right? It could be anything that will make this transparent lens become more opaque will cause cataract. So whitening of this, opacification or whitening of this lens causes cataract. Whitening of this lens causes cataract. So something that is transparent all of a sudden starts becoming opaque, hence the patient can't see. And usually they call it the red reflex. So when you flash light on the eye, it's one of the causes of red reflex. When you flash light on the eye, you see, I don't know how, I wish I had a picture to show you guys this thing, right? So you see something like this, right? So usually the eye is supposed to be red. The eye, when you flash light on the eye, I don't know if I can show you guys a diagram of this. Let me show you guys a diagram of this, right? So that you guys can see what I'm talking about, right? So this is the red reflex, right? So when you flash the light on the eye, you're supposed to see this, right? You're supposed to see this. This is what you're supposed to see. The eyes have like kind of like the red, and the redness is because light passes through the lens and the pupils and gets to the retina, and so you can have a peak of the retina, right? But when you can't see this, when you can't do this, when you flash the light and you don't see this red reflex, it means that something is blocking light from getting to the retina, and hence you can't see that retina, right? So that loss of the red reflex is what you have in cataract, just like what this patient is having. Basically, you can see that this eye, you can see that redness here, and in this patient, you can't see that. So basically, that's what happens in cataract, right? And there are many causes like listed: infection, metabolic disease condition, congenital disease conditions. Those are a lot of things that can cause cataract, right? And I mentioned about this neurofibromatosis too. It's more common You should know this because it's very high yield for the exam. Glucocorticoid is another very high yield course that you should know, right? How do you treat how do you treat it? Surgical removal. It's as simple as that. No difficult thing here. Then lens dislocation. What you just need to know is the disease that causes it, right? Marfan syndrome, homocystinuria, the two common causes. You just need to know this for the exam. There's not much stuff here that I would emphasize, right? So the reason why we're studying this basically, what you need to know from this diagram is two things, right? It's two things I just want you guys to know from that diagram, and it's important. The first thing that I want you guys to know from that diagram is the pathogenesis of glaucoma, right? Yeah,
Doctor, could you
yeah, I
please
can hear
tell
you.
me what is red reflex?
Okay, so basically, red reflex. So let me explain this simply, right? So this is the
Yeah.
eye,
Okay.
right? Right, this is the eye. This is like the pupils, right? At the back of the eye, you have the retina, right? You have the
Yes.
retina, the back of the eye, right? Okay, let me use the red color to signify the retina, right? This is the retina. So this one eye, this another eye. This is the retina of the other eye, right? This is the eye. Sorry, let me clean this. This is the retina. So this is the eye, right? So when you flash light on the eyes, right? This is like a light source, right, on the eye, right? When you flash it on the eyes, right, on this patient's eyes, you have like a sneak peek of what the retina looks like, right? Because there's a hole here, just like what you see when you flash lights in a box. This experiment that they used to do when we were in school. So I want to like show you guys something. Right? When you were in school, there's this experiment that we do as science students, right? So this is
I think it's with the ophthalmoscope is when we learn how to explore the eye. And
yeah, no, that one is fundoscopy. That is yeah. So that's fundoscopy. What you're talking about is fundoscopy. You use the ophthalmoscope to view the eye. But no, this one is different. Basically, you are flashing the
okay.
eyes with a you are pointing lights to the patient's eye, but at a particular distance. So you're not looking into the eye, you're just flashing lights at the eye, right? When you're flashing lights in the eye, because there's a space here, you can have a sneak peek. I call it a sneak peek, like um a limited view of what the retina looks like, right? So when you flash a light at the patient's eye, right, because there's a hole here, you can see the back here because of the light. The light passes through the pupils and lands on the retina. So at a particular distance, you can have a sneak peek of the retina by flashing light at it, right? That sneak peek you are seeing, that sneak peek you are seeing when you flash that in the eye can manifest as if it's at the pupils. Like, what do I mean? What am I trying to explain here? I'm trying to explain that when you flash a light to the patient's eye, right? Let me break it down for you so you can understand. When you flash light at the patient's eye, so when you flash the light at the patient's eye, right? When you flash a light at the patient's eye at a distance, this redness you are seeing, this red reflex you are seeing, is because it's hitting the retina. So you're kind of like seeing the retina, but from at a certain distance outside, right? You're having a sneak peek. You're having an idea of what goes on in the retina. This one is more clear. So they flash the light at the patient's eye, and when they flash the light at the patient's eye, you can see that you are seeing this redness here in the pupils, right? That redness you are seeing is the retina. This is not fundoscopy. Fundoscopy means that you use an instrument to look directly into the eye. So you are bringing let me show you what I'm talking about. So fundoscopy, right? So you can see this is fundoscopy. So you're using a light to kind of like look into the patient's eye. But for a red reflex, what you're doing is that you're using a pen touch. You're just pointing a pen touch at the patient's eye. You're not looking into the patient's eye, right? You're flashing a pen touch at the patient's eye to just elicit this red reflex. So what you're supposed to do when you flash a light at the patient's eye, right? The light will pass through these pupils and hit the back of the retina. So at a particular distance away from the patient, you would see this redness, that back of the retina, when you flash a light from the patient. As against when you use a fundoscopy, when you do fundoscopy. So when you do a fundoscopy, you're using an instrument now to just look directly through that pupils to see the back of the retina. So one is like you're using an instrument to focus at the retina, and the other one is that you're just flashing light, and when you flash light, a red color just flashes back at you, basically. That's what's just happening in the red reflex.
We
You are
can say
flashing light
that
at
we can say it's just a flashlight test
yes.
and say that. Okay.
Yeah, so it's like if it's a red flash of light that you can see when you direct a light source at the eye. So a flash of red light you can see on the pupils when you just use light to look at the eye from a distance, like from a far distance, right? When you use a pen touch to point the light at the patient's eye, you see a red light flashing back at you. That is called the red reflex. I don't know if that makes sense, guys.
Yes.
Okay. So the reason why they are drawing this diagram for you is to know basically one thing here, right? The first thing they want you to know from that diagram is that there is something known as the aqueous humor and the vitreous humor, right? So the eye has two parts. So this is the eye. Let's say this is the eye, right? Let's say this is the eye. This is the eye, right? Right. So this is the lens. So you divide this part into this is the anterior segment, posterior segment. This part has the what we call the vitreous humor. It's like a collection of fluid, a sticky like fluid that's located in the eye. Vitreous humor. It's like a sticky, clear fluid, right? That is found in the posterior segment, the part that is close to the lens, the part that is close to the retina, sorry. And then there's a fluid here around this region here called the aqueous humor, right? Right? And then they're trying to let you understand that one, there is a pathway through which this aqueous humor leaves the primary source, which is produced, and leaves, it's being produced, it circulates this whole region, and then it's drained out, right? That's what that thing wants to tell you. And then the part where it is drained out has an angle, right? And that angle is usually very open for the aqueous humor. So it's produced here around this region here. It's produced here, and then it goes around, and then it drains in this angle and leaves, right? So it's produced at this region here. It goes around the lens, nourishes this whole region. The major function of this fluid is to nourish the lens and other structures, and then it goes there. So it's produced by the choroids. It's produced by the choroids. The choroid, which is the middle layer of the eye. It's produced by the choroids. And then when it's produced by the choroid, it circulates the anterior chamber. It goes round and then it drains in this angle. This angle is known as has what we call a canal of Schlemm. It has an angle and it now drains into the canal of Schlemm. So about 90% of the fluid here drains through this pathway, through this mesh pathway that's located in the canal of Schlemm. That's what they're just trying to show you here. So you can see that 90% of the aqueous humor that is produced goes through the anterior chamber, and then it drains in this acute angle here, and then leads through the canal of Schlemm here. The other pathway through which it goes through is through the uveoscleral pathway, right? But this basically is not what you need to know for the exam. This is not the high yield thing you need to know for the exam. What you need to know, why this is very, very important is because of the pharmacological implication, right? And the pathogenesis here, right? So what happens basically in a disease condition called glaucoma is that there's increased intraocular pressure. So the pressure that is exerted by this fluid that is produced here, when it is increased, I told you there's a fluid produced here, which is the aqueous humor. When the pressure that is exerted by that fluid increases, it causes glaucoma, right? There's a fluid that goes down here and enters, the aqueous humor. It enters and leads through this network here, final network known as the canal of Schwann. If there is a blockade of this angle here, it leads to a buildup of pressure in the eye, and that leads to an increase in intraocular pressure, and that causes glaucoma. So there are two types of glaucoma basically. There's the open angle, meaning that this angle here through which the fluid drain is open, and then there's an acute angle closure glaucoma. So I have to wrap this up, guys. I'm almost right. And so when this angle is blocked, you have acute angle closure glaucoma. When it's open, you have an open angle. This acute angle closure glaucoma is an ophthalmic emergency. So you have to treat the patient almost immediately. You have to give drugs. You have to intervene. Some people go surgically and try to kind of like perforate this the iris here so that the fluid can easily go, or try to reduce the production of the fluid. So you have to do something for the patient. If not, the patient will go blind because this pressure will just keep increasing and increasing, and then the patient won't be able to carry out any, will have a very, very significant loss of vision. For this acute angle closure glaucoma, the patient presents with a hard orbit, hard, fixed, dilated pupils. That's what the patient will present with. Fixed, dilated pupils. That's what the patient will present with. The eyes will be red, right? So it's another differential of red eye. Fixed, dilated pupils, right? And the orbit will be very hard because of the fact that the pressure is so much there. The orbit will be hard because there's pressure building up there, right? What you need to know for the exams, I'm just going to emphasize on what you need to know for the exams, is the medication you need to use for them. So the medications, we're going to talk about that in pharmacology basically, but let me just highlight that, right? So in glaucoma, the drugs you're going to use are drugs that are going to reduce the pressure in the eye. So the drugs basically will do two things. The drugs will do two things. So you're doing two things when you give the medications. And it's what I want you guys to remember for the exam, right? What I want you guys to remember for an exam, for acute angle closure, it's emergency. You have to use surgery to treat that. But for open angle, the drugs you use, I call them the BAT drugs, right? So this is acetazolamide. So this is acetazolamide, beta blockers. So beta blockers. Right? Which can be propranolol or, right? You can use that. And then the next drug you're going to use here is acetazolamide. Acetazolamide. So use that as acetazolamide. Right? Here you can use timolol. So let me clean this up. So the drug here I want to write is brominidine. Brominidine, and here you can use timolol. Right? So brominidine, acetazolamide, timolol is what you use for open angle. Right? Open angle. And then for closed angle, of course, you have to intervene, you have to do surgery, you have to create a temporary outlet so that the pressure doesn't overbuild and then it leads to blindness. Okay. I think we're going to stop here for today. I wish I could finish ophthalmology with you guys today. I wish I could, but unfortunately, I won't be able to do that today. I won't be able to do that. There's a lot we have to talk about in ophthalmology because there's so much. So I think we'll have to move it to tomorrow, guys. I wish I could finish ophthalmology. That was my aim, to finish ophthalmology with you guys. That's why I was a bit fast. I want to try and finish it up so that we can do the slideshow. The slideshow is one of the most important part of neurology. That's why I wanted to do that today. So maybe tomorrow, maybe that's what I'll start with. I'll do the slideshow with you guys, and then I'll try and use the remaining 1 hour to um, um, treat ophthalmology and then the neuropharmacology. I just have to leave you guys at this point. Okay. I know it's a bit fast, guys. I know I was a bit fast for this particular one. I was just trying to see how I could round up ophthalmology because I want to do slideshow with you guys tomorrow. I want to show you guys a lot of slides, histology, CT scan, and okay, okay. I'm really sorry, Dr. Nafia. I
Yeah,
won't go fast tomorrow.
yeah.
I won't go
So,
fast
doctor,
tomorrow.
if you
Trust me, I'll be very, very slow.
yeah, if you need, you can take 1 day more. So it would be better for us to go little slow because if you cover more topics in a day, so sometimes it feels overwhelming to us. I don't know about others. So it is little better for us to just like try to cover less topics and route. That's why by this way you can retain more and not feel overwhelmed.
Yeah, yeah. Okay, so okay. Dr. Fatima, that's a great idea. The next class I'm going to have with you guys, I'm going to be very slow. The session is going to be very, very slow. I'm going to take my time and explain everything. Um, the other part of ophthalmology and neuropharmacology, I'm also going to be slow. I hope I can finish this by Wednesday latest. So tomorrow I'm going to spend so much time. I'm going to explain a lot of things. So that you guys can get it. I'm really sorry about today. I had to be fast so that I can cover so much. Neurology is very long. Like it's a very long topic. Like if I want to take my time to teach you guys neurology, I'll spend like 5 hours. If I want to go into details, every details, like I'm going to spend like 5 hours a day minimum to like make sure you guys can get it. But we don't have time, and I'm trying to just see how I can round it up as soon as possible, right? So I'm really sorry about that, guys. The next class I hope it will be more slower so that you guys
It's
can
so
gain it.
yeah, it's just our suggestion. Like if you could do this, it would be better for us.
Yeah, no problem. I'll try and tomorrow I'm not going to be fast. I promise you guys I'm not going to be fast tomorrow. I'm going to be very, very slow because the slide session is very, very key in neurology. In fact, when you master the slide session, you can get a lot of your questions on the steps just by knowing the slideshow. So I'm going to show you guys the slideshow and tell you guys what you need to know. I'll be very, very slow. I'll explain many things for tomorrow's class. Okay. Okay. So I'll see you guys tomorrow. You guys should get ready for the slideshow. It's going to be very, very informative. You're going to learn so much on the slideshow.
Thank you.
Thank you,
Yeah.
doctor.
Yeah.
Thank you, Doc.
Thank
Yeah.
you.
Thank you.
Yeah. Yeah.